lecture is anti-diuretics. In this part of the video lecture, we will be talking about synthesis, transport, storage and release of anti-diuretic hormone or vasopressin, the stimulators of vasopressin secretion and the actions of vasopressin, the renal actions and the non-renal actions of vasopressin. So starting off with what are anti-diuretics? An anti-diuretic is a substance that helps to maintain fluid balance by causing conservation of water, that is, it acts opposite to the diuretic effects. Some of the examples of anti-diuretic hormones are vasopressin, desmopressin and terlipressin. So how is vasopressin synthesized, transported, stored and released into the circulation? Vasopressin or antidiuretic hormone is synthesized as a peptide prohormone in the neurons of the hypothalamus. It then travels down the axon and terminates in the neural lobe of the posterior pituitary where it is stored in the vesicles. It is then released into the circulation in response to plasma osmolality. Once it is released into the circulation, the epithelial cells of the renal collecting duct system causes conservation of water, concentration of urine and produces effects opposite to that of diuretics. Some of the other sites where vasopressin is synthesized are the heart and the adrenal medulla. Vasopressin is released from the heart in response to elevated wall stress. It acts on the coronary blood vessels causing coronary vasoconstriction and causes impaired ventricular relaxation. Vasopressin is also released from the adrenal medulla and it causes increased release of catecholamines from the chromatin cells of the adrenal medulla. It stimulates the growth of the adrenal cortex and causes increased aldosterone synthesis. So next we move on to the stimulators of vasopressin secretion. One of the most important stimulator of vasopressin secretion is increased plasma osmolality. Also changes in effective arterial blood volume or blood pressure stimulates vasopressin secretion. Pain, nausea, vomiting, hypoxia and pharmacological agents can modify or regulate vasopressin secretion. One of the most important factors that stimulate vasopressin secretion is increased plasma osmolality. The threshold for vasopressin secretion is 280 milliosmolar per kilogram. A 2% increase in plasma osmolality can cause 2 to 3-fold increase in vasopressin secretion. So, increased plasma osmolality can increase the vasopressin levels in the body. It has been observed that increased salt load stimulates the hepatic portal osmoreceptors and this stimulates or increases the plasma osmolality and increases the vasopressin levels in the body. The next factor that stimulates vasopressin secretion is hypotension and hypovolemia. Decreased blood volume due to hemorrhage, congestive heart failure, hepatic cirrhosis associated with ascites, diuretics, sodium depletion and certain hypotensive drugs, acute adrenal insufficiency can stimulate vasopressin secretion and increase the levels of vasopressin. So, decreased blood volume or decreased blood pressure is associated with high vasopressin levels. Next, there are certain hormones and neurotransmitters that can stimulate or inhibit vasopressin release. Examples of these agents that stimulate vasopressin secretion are acetylcholine that stimulates the nicotinic receptors, histamine that stimulates the histamine receptors, dopamine stimulates the D1 and D2 receptors, substance P, neuropeptide Y, glutamate, aspartate, prostaglandins and angiotensin II stimulate vasopressin secretion, whereas actyl natriuretic peptide, gamma-aminobutyric acid inhibit vasopressin levels in the body. Lastly, there can be pharmacological modification of vasopressin secretion. The non-steroidal anti-inflammatory drugs reduce prostaglandin-induced renal blood flow. By decreasing the renal blood flow, they decrease the diuretic response and increase the anti-diuretic effects. carbamazepine and chlorpropamide enhance the antidiuretic effects of vasopressin, and demiclocycline reduces or attenuates the antidiuretic effects of vasopressin. So, in a well-hydrated person, the plasma osmolality is in the normal range and the vasopressin levels are low. Due to reduced vasopressin levels, the collecting duct is relatively impermeable to water. So, this causes increased excretion of water, causing dilute urine. But when the person is severely dehydrated, the plasma osmolality increases. So this acts as a stimulator for vasopressin secretion. So the vasopressin levels are increased, and due to increased vasopressin levels, the vasopressin acts on the renal collecting duct, which causes increased conservation of water, increased reabsorption of water, causing concentration of urine, and the effects are opposite to that of the diuretic effects. So in this way, it causes anti-diuretic effect. So what are the underlying mechanisms that cause renal conservation of water by anti-diuretics? The primary site of action of vasopressin is the collecting duct. So vasopressin acts on the principal cells of the collecting duct by acting on the vasopressin receptors, which are of two types, V1 and V2 receptors. The V2 receptors are expressed on the basolateral membrane of the collecting duct, and stimulation of V2 receptors causes activation of the GS adenylyl cyclase pathway. So increased stimulation of adenylyl cyclase enzyme causes increased formation of cyclic AMP. So increased formation of cyclic AMP stimulates or increases the insertion of the water channel vesicles in the apical membrane and reduce endocytosis of the water channel vesicles. So due to increased insertion of water channel vesicles and reduced endocytosis of water channel vesicles, there is increased expression of water channel vesicles in the apical membrane, and this causes increased reabsorption of water and produces antidiuretic effects, causes concentration of urine, reduces the urine output, and helps to maintain the blood volume of the body. Secondly, it is known that concentration of urine depends on hypertonicity of medullary interstitium, and hypertonicity of medullary interstitium depends on increased urea deposition. Vasopressin receptors, particularly V2 receptors that are expressed in the terminal portion of the medullary collecting duct, stimulates the vasopressin regulating urea transporter that causes increased deposition, increased accumulation of urea in the medullary interstitium. This increases the tonicity in the medullary interstitium. So increased tonicity of the medullary interstitium due to increased urea deposition, which in turn is due to increased stimulation of the VRUT, that is vasopressin regulating urea transporter, and this helps in concentrating urine and antidiuretic effects of vasopressin. Thirdly, vasopressin acts on the epithelial cells of the ascending limb of loop of Henle. This causes increased expression and translocation of transporters, that is sodium potassium chloride cotransporter, in the ascending limb of loop of Henle, and this causes increased reabsorption of sodium from the tubular lumen into the interstitium and decreasing the excretion of sodium. So the effects are opposite to that of diuretics. So vasopressin, by increasing the sodium transport, by increasing the expression of the transporters in the ascending limb of loop of Henle, increases the sodium transport and produces antidiuretic effects. So to sum up the renal actions of vasopressin, vasopressin primarily acts on the collecting duct, and this causes increased conservation of water, helps to maintain blood volume, produces antidiuretic effect, and causes concentration of urine. The underlying mechanism involves increased stimulation of V2 receptors in the collecting duct, which increases renal conservation of water, and increased urea deposition in the medullary interstitium. And thirdly, There is increased expression of sodium channels in the ascending limb of loop of Henle that causes increased sodium transport into the interstitium and producing effects opposite to that of diuretics, leading to concentration of urine. So now that we have learnt about the renal actions of vasopressin, so let's now move on to the non-renal actions of vasopressin. Vasopressin receptors are of two types, V1 and V2. The V2 receptors are predominantly expressed in the kidney and the V1 receptors are expressed in the blood vessels, particularly the coronary blood vessels and blood vessels of the GI tract and brain. So stimulation of V1 receptors of the blood vessels causes increased vasoconstriction and increases the resistance in the blood vessels. Thus, stimulation of V1 receptors of the coronary blood vessels causes constriction of the blood vessels, decreasing the cardiac output, decreasing the heart rate. It has been observed that patients who are treated with small amount of vasopressin for the treatment of diabetes insipidus can experience ischemic pain. So this may be due to decreased cardiac output resulting from V1 receptor mediated vasoconstriction. V1 receptors are also expressed in the platelets and stimulation of V1 receptors of the platelets causes platelet aggregation. The stimulation of V1 receptors of the liver stimulates glycogenolysis and increases the glucose output. Next is blood coagulation. The stimulation of V2 receptors by vasopressin increases the secretion of coagulating factors such as factor VIII and von Willebrand factor. So increased secretion of coagulation factors, that is factor VIII and von Willebrand factor, due to stimulation of V2 receptors. So in today's session we have learned what is an antidiuretic substance, how is the antidiuretic substance or vasopressin synthesized, transported and released into the circulation, what causes stimulation or regulation of vasopressin secretion, the actions of vasopressin, the renal actions, the non-renal actions.
This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.